Welcome. In this session, we will be discussing the disorders of seventh nerve, and we will be broadly discussing this disorder under two heads: those with underaction of the facial nerve and those with overaction of the facial nerve. Functionally, the facial nerve has three components: motor, autonomic, and sensory. In an ophthalmology setting, we are more interested with the motor function of the facial nerve, and we look at the symmetry of the facial expression, palpebral aperture width, and blinking of the eyes. And we also ask the patient to close the eyes, smile, and wrinkle the forehead in order to assess the function of the facial nerve. Budding of eyelashes may also be a sign of dysfunction of the facial nerve. Autonomic function of facial nerve includes lacrimation and salivation, and sensory function of facial nerve includes taste from anterior two-thirds of the tongue and sensation from the posterior wall of the external auditory meatus. We also check for aberrant regeneration following facial nerve injury, and this can occur after any lower motor neuron lesion of the facial nerve. Most commonly occurs after Bell's palsy. In aberrant regeneration, we can have twitching of the corners of the mouth on attempted blinking and vice versa. Crocodile tears is another sign of aberrant seventh nerve regeneration, and patients with crocodile tears have lacrimation during chewing. This usually occurs from a severe injury to proximal portion of the facial nerve. We start with the disorders causing underaction of the facial nerve, and among them Bell's palsy is the most common cause of underaction of the facial nerve. When we encounter a patient with underaction of the facial nerve, the first step is to distinguish a lower motor neuron lesion from an upper motor neuron lesion. The upper part of the face is supplied by the upper motor neurons of either side bilaterally, but the lower part of the face is supplied by only the contralateral upper motor neurons. But the lower motor neurons of the motor nucleus of the facial nerve supply only the ipsilateral face. So in an upper motor neuron lesion, only the contralateral lower half of the facial muscles will be affected, and sparing of muscles of the upper face is detected by asking the patient to look up and raise the eyebrows, thus demonstrating sparing of frontalis muscle action. A lesion of the upper motor neurons interrupts innervation of only the motor nucleus of the facial nerve, so taste and lacrimation and salivation are spared with upper motor neuron lesion. And in a lower motor neuron lesion, entire ipsilateral face, that is both the upper and lower half of the face, is affected. Depending on the location of the lesion, taste and lacrimation salivation can also be affected in a lower motor neuron lesion. An upper motor neuron lesion or supranuclear lesion affecting facial nerve function can be either in the motor area in precentral gyrus of the frontal cortex or in the extrapyramidal system. If the lesion is in the precentral gyrus, then voluntary movement of contralateral lower face is affected. However, emotional expression and blink rate is normal. But if the lesion is in the extrapyramidal system, then the emotional expression and blink rate are reduced, but voluntary facial muscle action is paired. A lower motor neuron lesion of the facial nerve can be either in the nucleus of the facial nerve located in the pons or in the infranuclear portion of the facial nerve. Nuclear lesion of the facial nerve is caused by a pontine lesion, most commonly a stroke or a tumor, and the ipsilateral entire face is affected, that is both the upper and the lower part of the ipsilateral face will be affected. And since the lesion may also affect other structures within the brainstem at the level of the pons, a nuclear facial nerve palsy may be associated with deficits of the fifth cranial nerve, and the sixth cranial nerve can be associated with contralateral hemiparesis and ataxia. And the pontine lesion may affect either the motor, the autonomic, or the sensory function, or any combination of the three. Mebius syndrome is a congenital syndrome in which there is a developmental defect in cranial nerve 6 and cranial nerve 7 nuclei. Infranuclear lesion of facial nerve is characterized by Bell's palsy, but Bell's palsy is a diagnosis of exclusion after we have excluded supranuclear, nuclear and other causes of infranuclear lesions of the facial nerve. As we have mentioned, Bell's palsy is the most common cause of facial nerve palsy, and the patient presents with a sudden onset of unilateral facial palsy. Both the upper and the lower halves of the face are affected. As we have also mentioned, it may be associated with impaired lacrimation and taste sensations as well as hyperacusis. There may be pain with Bell's palsy and it may precede or occur with the palsy. Bell's palsy is usually associated with facial numbness, but facial sensation is intact. Etiology of Bell's palsy is unknown. Bell's palsy is more common in pregnancy and diabetes mellitus. It usually starts to improve within 3 weeks. In the majority of patients, the recovery is complete within 3 months with only subtle signs of synkinesis. Impaired recovery suggests other etiologies. In the remaining 15% of Bell's palsy patient, recovery is incomplete with prominent synkinesis. Treatment of Bell's palsy includes oral corticosteroids initiated within the first 72 hours of onset. Neoplasms can also cause infranuclear lesion of the facial nerve, and the locations of these lesions can be either in the cerebellopontine angle, in which case the 5th cranial nerve, the 6th cranial nerve and the 8th cranial nerve is also involved. The lesion can be in the fallopian canal within the ear and the parotid gland, or it can be a meningeal infiltration, in which case the facial nerve palsy can be bilateral. Facial nerve palsy from neoplasms has an insidious onset and a slowly progressive course, with the exception of meningeal carcinomatosis, which has a rapidly deteriorating course, and neoplasms have significant synkinesis. Infections may also cause infranuclear palsy of the facial nerve, and Ramsay-Hunt syndrome is the name given to herpes zoster infection of geniculate ganglion. Like herpes zoster ophthalmicus, these patients complain of severe pain with post-herpetic neuralgia, and we may find vesicles in the posterior aspect of the external auditory meatus, tympanic membrane and pinna. Other infections causing infranuclear facial nerve palsy include Lyme's disease, HIV, seroconversion, infections of the middle ear and meningitis. Inflammations may also involve the infranuclear facial nerve, and in sarcoidosis, facial nerve is the most common nerve to be involved, and usually the involvement of the facial nerve in sarcoidosis is bilateral but asymmetric, and this occurs when the parotid gland of either side is involved. Bilateral cranial nerve 7 palsy may also occur in Miller-Fisher variant of Guillain-Barré syndrome, in which case it is associated with ophthalmoplegia, ataxia and areflexia, and CSF analysis shows elevated protein with a normal cell count. And these patients shows serum antibodies to GQ1b. Myasthenia gravis can affect the neuromuscular junctions of orbicularis oculi and resemble infranuclear facial nerve palsy. And Melkerson-Rosenthal syndrome is characterized by recurrent attacks of either unilateral or bilateral 7 cranial nerve palsy with facial swelling and tongue furrows. Trauma may injure the infranuclear facial nerve, and this is usually associated with a temporal bone fracture, and will find ecchymosis over the mastoid bone. Even birth trauma can cause a congenital facial nerve palsy. Whenever we encounter a patient with facial palsy, we must always check corneal sensation, because both cranial nerve 5 and cranial nerve 7 provide protection to the cornea from external environmental insults. And in situations where both cranial nerve 5 and cranial nerve 7 are involved, there is a very high risk of rapid corneal deterioration, and treatment needs to be very aggressive. And whether we have an isolated facial nerve palsy or one combined with cranial nerve 5 palsy, the cornea must be protected with lubricating drops and ointment, lid taping or tarsorrhaphy. Tarsorrhaphy is very effective but is cosmetically disfiguring. Other options in this scenario are moisture goggles, botulinum toxin to paralyze the levator palpebrae superioris so that it does not elevate the lid, and gold or platinum weights may be inserted in the upper lid in order to lower the upper lid. These methods are used because they allow MRI. Now we come to overaction of facial nerve, and the two most important disorders causing overaction of the facial nerve are benign essential blepharospasm and hemifacial spasm. In benign essential blepharospasm, there are recurrent episodes of bilateral orbicularis overaction. Initially, orbicularis overaction is mild and infrequent, but later the frequency and the severity of orbicularis overaction gradually increases, and it can become severe enough so that the patient is unable to open the eyes and is functionally blind. The onset of benign essential blepharospasm is usually between 40 and 60 years. It is said to be a basal ganglia disorder, and it can be associated with facial grimacing, in which case it is called a Midge syndrome. Benign essential blepharospasm reduces or disappears with sleep and is exacerbated with stress. Benign essential blepharospasm does not have any other associated signs and symptoms, and its differential diagnosis include reflex blepharospasm from dry eye, anterior uveitis and meningismus, functional blepharospasm which decreases when the patient is distracted, and blepharospasm in extrapyramidal disorders such as Parkinson's disease, Huntington's disease and basal ganglia infarction. When benign essential blepharospasm interferes with quality of life, then it must be treated, and the treatment of choice is Botox injection in orbicularis oculi. On each side, botulinum toxin is injected at 4 to 8 sites, and it starts acting after 2 to 3 days. The maximum effect occurs between 1 to 3 weeks, and the effect lasts for 3 months and thus needs to be repeated. One must avoid injecting in the middle of the upper lid to decrease the risk of lagophthalmos. Complications include lagophthalmos due to underaction of the orbicularis oculi, ptosis due to underaction of levator palpebrae superioris, diplopia due to underaction of the extraocular muscles, ectropion, epiphora and exacerbation of dry eye. So dry eye is a relative contraindication of Botox injections. Treatment options in recalcitrant cases includes surgical myectomy of orbital and palpebral orbicularis, but this may be associated with lagophthalmos, lymphedema and lid contour deformities, or ablation of selective branches of the facial nerves. Sedatives and muscle relaxants can control mild cases or prolong the interval between Botox injections. Coming to the next important disorder with overaction of the facial nerve, hemifacial spasm is characterized by recurrent episodes of synchronous contractions of unilateral facial muscles. So in contrast to benign essential blepharospasm, which involves orbicularis oculi muscles bilaterally, hemifacial spasm involves the entire face, both the upper and the lower face, unilaterally. Hemifacial spasm often starts with the orbicularis oculi and then spreads to the rest of the ipsilateral face. The episodes lasts for seconds to a few minutes, and the episodes are waxing and waning in intensity. In contrast to benign essential blepharospasm, which disappears during sleep, hemifacial spasm occurs during sleep, and the most common cause of hemifacial spasm is said to be compression of the exit of cranial nerve 7 from the brainstem by an adjacent dilated artery. Other causes of hemifacial spasm can be cerebellopontine angle tumors and aberrant regeneration of the facial nerve after Bell's palsy, trauma or demyelination. Unlike blepharospasm, imaging is indicated in hemifacial spasm, and in hemifacial spasm, like benign essential blepharospasm, Botox injection is the treatment of choice, and Botox is injected both in the orbicularis and the other facial muscles. It is very effective and is the treatment of choice, and hemifacial spasm requires lesser dose than benign essential blepharospasm. Sedatives are less effective in hemifacial spasm, and in recalcitrant cases, microvascular decompression of the nerve root can be done, but it involves a high surgical risk. Spastic paratic hemifacial spasm, as the name suggests, has a combination of both spasm and paralysis. It is a unilateral phenomenon, and it begins with myokymia of the orbicularis and then spreads to the remainder of the ipsilateral face. And there is both initially ipsilateral tonic contraction of the facial muscles and later on ipsilateral weakness of voluntary contraction of the facial muscles develop. The cause is a pontine lesion, usually a neoplasm. Facial myokymia consists of unilateral fibrillary contractions of muscle in one side of the face, and it appears as undulating or rippling movement, and it also results from a pontine lesion, usually a glioma in childhood or demyelination in adulthood, and thus requires imaging. Benign eyelid myokymia is a common condition we encounter in the clinic, and it consists of intermittent episodes of unilateral contraction of the orbicularis oculi, and these episodes usually lasts for weeks to months and is provoked by stress, caffeine and sleep deprivation. There are also other causes of facial muscle spasm. They include habit spasm, which usually occurs in childhood but disappears later and can be controlled with command, and they are involuntary and repetitive contractions of the facial muscles. Focal cortical seizures can also cause facial muscle spasm, and tardive dyskinesia, a side effect of antipsychotic therapy, may have cross jerky movements of the facial muscles. Thank you for listening.